respected doctors, good evening to all of you. To speak on the today's topic, advancement in the risk stratification and management strategies for atherosclerotic cardiovascular disease and acute coronary syndromes. So you all know that the dyslipidemia is one of the important risk factors for the vascular diseases. It is nothing but an imbalance of the lipids. It could be due to either the lipoprotein overproduction, leading to the increased total cholesterol, increased LDL cholesterol, or increased triglycerides, or sometimes in a deficiency. So most important one is a protective cholesterol at a lower level, that is a HDL cholesterol at a lower level. See, unfortunately, 80% of our Indians are having the low HDLC cholesterol. So you all know that the normal HDLC cholesterol in the males should be more than the 40 and in the females more than the 50, and triglycerides less than the 150 is our goal. LDLC cholesterol less than the 50 or the 75 is our goal, and the total cholesterol less than the 200 is our goal. But unfortunately, most of our Indians are having the dyslipidemia. So the dyslipidemia has been strongly associated with the pathophysiology of the CVDs. It is a major independent risk factor and further leading to the development of the atherosclerosis, mostly the premature atherosclerosis, and associated cardiovascular events leading to either the myocardial infarction or cardiovascular disease, cerebrovascular disease, or the peripheral vascular diseases. Now it has become a growing burden across the globe in general and India in particular because of the more smoking, more diabetes, more hypertension in our population. The developing countries like India alone accounts for about 80% of the global CVD mortality. So that clearly shows that the value of the dyslipidemia management in our day-to-day practice. You are all familiar with this ICMR India study. This is a very big study published in the 2021 December. It clearly shows that the number of the diabetics in India are to the tune of about 10.1 crores and the pre-diabetics about 13 crores. And if you combine the dysglycemia, nearly to the tune of about 25 crores by this time. And hypertensives, more than 31 crores are the hypertensive in India. And the obesity, we are having the more abdominal adiposity, which is very bad because it contains more the visceral fat and more atherosclerotic fat and the adiponectins, lower adiponectin levels, higher leptin levels, etc. About 35 crores are having the abdominal adiposity. And the dyslipidemia of C, about the 21.3 crores are the hypercholesterolemia, and about 18.5 crores are the high LDLC cholesterol. So if you see these projections with the high number of the diabetes, the hypertension, obesity, and dyslipidemia, you combine all these four, so that is a metabolic syndrome. So very high in number, at least 40 to 50% of our Indians more than the 18 years of the age group are in the metabolic syndrome. So if you see the prevalences here among the lipid profiles, lipids, so hypercholesterolemia about 24%, hypertriglyceridemia 32%, low HDL 66.9%, and high LDL 20%. So this is the Indian prevalence. India has seen a rapid increase in the prevalence of the CVDs. So you all agree with me that CAD manifests almost a decade earlier in India than in the Western population. Not even a decade, maybe the 2 or 3 decades earlier, we are seeing a lot of the CADs even at the age of 20 plus or 30 and 30 plus or 40, etc. Whereas in the Western population is more common, more than the 50 years of the age group. And incidence of the CAD is increasing most rapidly among the patients younger than the 40 years because of the urbanization and the motorization and because of the low physical activity and high calorie dense fruits, high calorie dense foods, that is the mostly fast foods, and sleeplessness. So these are the important environmental factors to cause the increased incidence of the CAD in young individuals. About 10 to 25% of the MIs in India occur before the age of the 40 years. And 50% of the coronary artery diseases associated with the deaths in India occur before the age of the 50 years. So this clearly shows that Indian diabetics or Indian hypertensives or Indian dyslipidemias or Indian CADs are clearly differentiate are different from the Western population. So we are seeing these diseases at an younger age group. So around the 20 or 30 or less than the 40 years of the age group. So as a physician or as a clinician, we should be very much familiar about all the vascular risk factors, and we have to control these vascular risk factors, and we have to keep these factors at a lower level so that our people will live for the longer period with good quality of the life, with less morbidity and the mortality. So among them, the dyslipidemia is one of the important factor to be focused. See, as I told you that the Indian population is at the high risk ethnic group for the development of atherosclerotic cardiovascular disease. So even though you are not having any family history of the dyslipidemia, being Indian genes itself is at high risk of getting the complications or the effects of the atherosclerotic cardiovascular disease. See, if you see here, they have given the high LDL-C cholesterol, low HDL-C cholesterol, the protective cholesterol at a lower level, and high triglyceride cholesterol. If you see here, the Asian Indians and the women and the men, so high LDL cholesterol is at a higher level, at a risky group in Indians. Low HDL-C cholesterol, again very high in our Indian, both the male and the females, and more in the males. And the high triglycerides, again the more in the males and the females as far as the Asian Indians are concerned. So that clearly shows that is the reason our people are at high risk of getting the atherosclerotic cardiovascular diseases because of the high LDL-C cholesterol, high triglyceride cholesterol, but low HDL-C cholesterol. So dyslipidemia in Indians is different from the Western population. See, this is the nice guidelines, 2023 UK guidelines, a draft updated guidance from the National Institute of Health and Excellence. It recommends that currently the guidance is that statins are offered to the people with a 10% or higher risk score. So those people who are having the risk of getting the cardiovascular events, a 10-year risk of the cardiovascular events, even though a 10% or higher the risk score, so definitely we have to use the statins. So the committee concluded that while statins can sometimes cause side effects, such as the muscle pains, the best evidence showed that most people do not experience these pains with the statins. So luckily Indians also, we use a lot of the people who use the statins in most of our population, like uncontrolled diabetes, hypertensives, post ischemic heart disease population, or in hypothyroid individuals, obese individuals, smokers. But fortunately, we are not having the much side effects of the statins, and the important side effect of the statin is the myalgia. It is very, very less in our Indian population. See, the statins, the dose recommendation is the high dose statin recommendations. So the statins can be divided into the three groups: low dose, medium dose, and the high dose statin recommendations. But our Indian population, they need either the medium dose statins or the high dose statins, but not the role of the low dose statins. So the evidence was limited here in the NICE guidelines. The committee agreed it was consistent with their clinical experience that a higher starting dose may be more appropriate for some people thought to be at higher risk of CVD and therefore more likely to benefit from the statins. So always use the statins at an higher dosages. Higher doses means rosuvastatin 20 to 40 milligrams and the atorvastatin 40 to 80 milligrams. So there is no role of the simvastatin in Indian population because atorvastatin and the rosuvastatin are superior to the simvastatin. So always better to use the at least 20 milligrams of the rosuvastatin or the 40 milligrams of the atorvastatin in most of our individuals to give them a lower risk to get the coronary artery diseases. See, compared to the other ethnic groups, Southeast Asians, Indians have higher prevalence of atherogenic dyslipidemia, higher prevalence of traditional risk factors, and the greater prevalence of the risk factors at a younger age group. You all know that the traditional risk factors like smoking, diabetes, hypertension, obesity, physical inactivity, a strong family history, etc. And lack of awareness on the CAD prevention. So that is a very, even today, so big thanks to our media. So every day they spare some time on our health bulletins. So stating that India is facing, is the diabetic capital, and more hypertensive individuals in India, and more cardiovascular diseases, etc. Even then, at least 40 to 50% of Indians, they are not at awareness group to know what is CAD, what is diabetes, what is hypertension, etc. So a lot to be done to improve the awareness about these vascular risk factors among the public, so that the primary prevention will be much better. See, always the primary prevention is better than the secondary or the tertiary prevention. Primary prevention is nothing but they should be aware of all these risk factors and they should act accordingly, not to have the disease at all. But unfortunately, most of our Indians, they are having the CAD without knowing that they are having the complication or the risk factors. So the dietary factors are very, very important, because our people nowadays, they are more and more fancy about the fast foods, which contains a lot of the saturated fats. They use a lot of the dalda, they use more saturated fats, and the trans fats are very high in these fast foods. And then the most important, PUFA and MOFA are at a lower level, and they consume a lot of the dense calorie diet. So these are all the factors responsible for increased incidence of the coronary artery disease. On the other hand, and very few fiber diet and very few fruits. So high fiber and high fruits are very, very good for the public not to have the atherosclerotic dyslipidemias. Physical inactivity secondary to the rapid urbanization. This is the important risk factor. So to understand clearly, simple sitting is is equivalent to your smoking. So risk of the smoking is equivalent to the sitting. So that means, so we have to always walk a while. So that is very, very important. So otherwise, the physical inactivity itself is a big risk factor. So everyone has to do at least 10 to 15,000 steps a day. So universal screening of all the Indians, because Indians are at high risk of getting the vascular events. So by years, 20 years or years. So I feel that from this screening should start from the age of say 17 or 18 years, because by the time they finish the intermediate, so definitely most of the people are pre-hypertensives, pre-diabetics, and also atherosclerotic dyslipidemic age group. So at the time of the college admission, at the earliest opportunity, so for the purpose of early detection of the high risk individuals, this is always advisable. Rule of the secondary causes of the dyslipidemia. So especially more obesity individuals because of the fast food intakers, and also the hypothyroidism is again important secondary cause of the dyslipidemia. Fasting lipid profile is not mandatory. So, but non-HDL cholesterol should be calculated in every subject. See, when you are getting the lipid profile on non-fasting levels, so the only difference is with the triglycerides. So whether you are getting the lipid profile on the fasting or the non-fasting, all the other values are the same except the triglyceride levels. So the triglyceride levels may go up after your prandial state. But most important thing is, in lipid profile, we get the 5 values. So serum cholesterol, triglycerides, HDL, LDL, and VLDL. But you have to get the non-HDL cholesterol. So this should be calculated in every subject. So how to be calculated? So you get the serum cholesterol, and you also get the HDL cholesterol. So you subtract the HDL from the total cholesterol, from the serum cholesterol. So that is your non-HDL cholesterol value. So this should not be more than the 30 of your LDL target. Suppose if your LDL target is 70, so non-HDL cholesterol should be less than 100. And if your LDL target is 100, then the non-HDL cholesterol target is 100 plus 30, 130. So that is the value of the non-HDL cholesterol. So the fasting is not mandatory. Identify the patient risks category based on the conventional and the non-conventional risk factors. So 2023 updated risk stratification given by the Lipid Association of India. We have the major atherosclerotic cardiovascular risk factors. These 4 are the major atherosclerotic cardiovascular risk factors. Age more than the 45 years in the males, and the more than the 55 years in the females. Smoking, blood pressure, and low HDL cholesterol. So these are the 4 major atherosclerotic cardiovascular risk factors according to your Lipid Association of India. See, if you see here, so the 1 and the 4 are very common in all the individuals in Indians, because we can't stop the age. So age more than the 45 years is a major risk factor for the males, and more than 55 years in the females. That means post-menopausal women. Low HDL cholesterol. 80% of Indians are having the low HDL cholesterol. Smoking and the blood pressure is other 2 major atherosclerotic cardiovascular risk factors. If you see the high risk features, so the family history of the premature atherosclerotic cardiovascular disease, that is also very common in our Indian population. CKD stage 3B or the 4, that means with GFR less than the 45, 30 to 45 is the 3B, and 15 to 30 is the stage 4. So the high risk starts from the 45 or GFR, but unfortunately, even at the 30, the most of the people are asymptomatic. So that is the reason. Whenever you see a case of the chronic diabetics and the hypertension, please get the creatinine levels and don't be happy with the creatinine alone. Get the GFR also done. According to the GFR, you can see these stages. Stage 3. 3 means 30 to 60 of GFR. That is divided into stage A and the B. See, apolipoprotein B more than 130 milligrams. So it is a very costly test. We have to send it for the higher labs. But apolipoprotein B directly indirectly tells you the value of your non-HDL-C cholesterol. I told you the non-HDL-C cholesterol, how do you get the non-HDL-C cholesterol? So you subtract the HDL from the serum cholesterol. So that is your non-HDL-C cholesterol. That is almost equivalent to your apolipoprotein B. And extreme elevation of a single risk factor, lipoprotein little a more than the 50. Metabolic syndromes. So the metabolic syndrome is nothing but the combination of all the 4. The Revance syndrome or insulin resistance syndrome. So the root cause for this metabolic syndrome is insulin resistance. And the fatty liver, non-alcoholic fatty liver disease with fibrosis grade 2 or the 3 is also a high risk feature. And coronary artery calcium score, so 1 to 99 and less than the 75th percentile is also at the high risk. Even calcium score, even a single digits, so again high risk. So it should be less than the 0. So 0 or 0. If it is the number 1 or the 2 or the 3 calcium score, it is a high risk individuals. See, again, these are very, very common in our society. See, as I told you that age is more common, low HDLs is common, family history is very common, and CKD stage is asymptomatic. That is also very common in our population. And extreme elevation of a single factor is common. Metabolic syndrome. So most of the people are metabolic syndrome in India. And fatty liver is the most important is also an extension of your metabolic syndrome. And is a very common ultrasound diagnosis nowadays. When for any reason, if you send the ultrasound abdomen, so immediately the radiologist diagnosis is fatty liver grade 1 or 2 or 3, etc. And calcium score, nowadays we are getting the calcium scores also, coronary artery calcium scores with your under your CT coronary calcium score. So this is also very common investigation nowadays. We are getting it. If it is more than the 1, so again at high risk individual. So more than the 400, so it's a very high risk and you have to subject for the coronary angios. Risk modifiers. So the lipoprotein little a 20 to 49 more than the 50 is very dangerous, high risk. Impaired fasting glucose, increased waist circumference, high sensitive CRP, triglycerides, so rheumatoid arthritis, psoriasis, spondyloarthritis, so all these rheumatological conditions is again a vascular diseases. Premature menopause, preeclampsia, gestational diabetes, PCOD, air pollution, HIV. So these are all the different risk modifiers. So now we concentrate on the risk groups. So concentrate on the very high risk individuals. So diabetes with the target organ damage. So target organ damage means diabetes with the neuropathy, or diabetes with retinopathy, or diabetes with microalbuminuria, or diabetes with LVH, or diabetes with carotid intima-media thickness, or diabetes with low ankle brachial index. So these are all the people are at high risk. So all these people are very common in our society, diabetes, because 40 to 50% of the diabetes they present with the complications at the time of the diagnosis itself. So they comes under very high risk individuals. Diabetes with more than the 2 major atherosclerotic cardiovascular risk factors, that is also very common, age more than the 45 in the males, etc., and low HDL-C cholesterol, and calcium score already I told you, and established atherosclerotic cardiovascular disease. So those people, some people know, so they present straight away they diagnose the diabetes only in the setting of the cardiac ICUs. So the family history. So these are the very high risk individuals. So the consider atherosclerotic cardiovascular disease to achieve the lipid goals as less than the 55. So this is the most important take-home point. So when you are thinking that atherosclerotic cardiovascular disease, their patient, so definitely our goal should be less than the 55. Even in the some population, even to reach the 30 is also needed. But even though it is very difficult to reach those goals with only with your statin therapy, but you need the a combination drugs, both the statins and the non-statins, to reach these goals. But one thing is very clear, that don't be happy of your LDLC cholesterol at 70 or 80 or less than the 100. So your goal should be less than the 70. Even if the fellow is atherosclerotic cardiovascular disease, definitely less than the 55. So, but it is very easy to say, but it is very, very difficult to achieve these levels unless you use the high intensity statins with non-statin drugs. So, combination drug therapy. So, what about the CSI guidelines? So, Cardiovascular Society of India. See the risk assessment. So, again, the extremely high risk individuals, high risk individuals, high risk individuals, and moderate risk. See, so diabetes with one or more risk factors is high risk. Atherosclerotic cardiovascular disease, very, very high risk. Extremely high risk, atherosclerotic cardiovascular recurrent episodes within 2 years in the same territory are the different, or polyvascular. Some people will have the CAD and also will have the CVA or the peripheral vascular disease, etc. They are extremely high risk individuals. Here the LDLC goal is less than the 40. In very high risk individuals, LDLC goal is less than 55. In high risk individuals, less than the 70. See here the LDLC lowering the marathon. See here the very important slide showing you a primary prevention, secondary prevention is very important. See primordial prevention pathway. So you have to identify the high risk individuals. So who are the high risk individuals? Indians itself, Indian gene itself is a high risk individual. All obese people are at high risk. All smokers are at high risk. Uncontrolled diabetes is a high risk. Again, the blood pressure more than 140/90 is at high risk, and dyslipidemia population are high risk. Or your waist circumference more than the 90 in the males and more than the 80 in the females. Again, it is a high risk individuals. So identify these high risk individuals, give the non-pharmacological management like your dietary approach, your physical activity, yoga, meditation, etc. And then you have to avoid the primary events. Suppose if the person already got some event, so then it is called as the primary prevention, not to have the secondary attacks. So in the secondary prevention, so these are very important cardiovascular health strategy. So here, when to start, whether to start or not, and then what is the dosage of the statins to be started. So these are the different questions, and very clear that statin is a must for most of our high risk individuals unless otherwise contraindicated. So the dose of the statin to be used is always 20 milligrams of the atorvastatin or the 10 milligrams of the rosuvastatin. So there is no role of the 5 milligrams of the rosuvastatin or the 10 milligrams of the atorvastatin in most of our diabetic or hypertensive or at high risk individuals, because 5 milligrams of the rosuvastatin and the 10 milligrams of the atorvastatin comes under only a mild to the moderate group. See here the statin intensity. So here you agree with me that your goal is LDLC reduction is more than the 50%. So you have to use the atorvastatin 40 to 80 mg or the rosuvastatin 20 to 80, 40 milligrams. Suppose high risk individuals. Suppose if the LDL is about say 110 or 120. So what is your goal in high risk individuals? Your goal is less than 55. So in that way, you have to reduce the LDL cholesterol more than the 50%. From 120, we have to reach the target of less than 55. So here it is very difficult to reach this value with 5 milligrams or the 10 milligrams of your rosuvastatin. Here you have to use the 20 to 40 and the atorvastatin 40 to 80 mg. So my appeal to all of you is please use high statins, high dose statins for most of our individuals to keep their vessels intact. Otherwise, even though you are using the statins, if the dose is not appropriate, so then definitely these people will have the more and more atherosclerotic events in the near future. So suppose your goal is reduction of the LDL goal is between 30 and 50. Suppose his LDL cholesterol is 80 and your goal is say 55. Then you can use this atorvastatin of about rosuvastatin of about 10 milligrams or the atorvastatin of 20 milligrams. So low intensity, so no role in Indian population. So this is the Lipid Association of India guidelines for the lipid targets. See here the low risk group, moderate risk group, high risk group. Your LDL target is always less than the 50, 70, etc. Recommended treatment goals for LDL lowering therapy, main changes, the same thing here. The importance of the LDL-C cholesterol lowering in atherosclerotic cardiovascular disease prevention. Lower for longer is the better. So the primary prevention is the estimated atherosclerosis, diabetes management, hypercholesteremia and familial cholesteremia management, secondary prevention, no established LDL-C lower limits, additional medications like oral ezetimibe, bempedoic acid. These two are very, very important drugs to be added to the statin in some individuals, not all the individuals, but some individuals you have to take the help of the ezetimibe along with your statins and the bempedoic acid. Now it is available at the dose of 180 milligrams, a good drug, especially for the statin intolerant population. So most of the 98% are statin tolerant. In the 2 to 3 or 4% are the statin intolerant, then you can use the bempedoic acid in them. Or otherwise, if you are not happy with the statins alone, you can add the bempedoic acid to the statins. Injectables, PCSK9 monoclonal antibodies. So this is useful for most of the cardiology friends. They use these PCSK9 monoclonal antibodies in some individuals when the LDL is very, very high. Novel agents like evinacumab for the homozygous familial hypercholesterolemia. So in conclusions, early, intensive and sustained LDL-C cholesterol lowering is crucial for both primary and secondary atherosclerotic cardiovascular prevention. See, early use and also intensive use, that is high statins. So you have to use the statins early and also high intensity statins to reduce your primary, to get your primary and secondary preventions. Expanding lipid treatment options enhance the management strategies, provided if you are not happy with the statins alone. So definitely you have to take the help of the ezetimibe and the bempedoic acid in some individuals. See here, the degree of the LDL-C reduction. Prolonged LDL-C reductions of the similar magnitude provide the greater risk benefits than the late reductions. So that means again, like our diabetic individuals, metabolic memory. So you have to start early. You have to reduce the blood sugars very effectively to avoid the long-term complications. The same thing also holds good for your statins therapy. So start early and high intensity statins. So what is new for the rosuvastatin? So rosuvastatin effect on the atherosclerotic plaque metabolism. So investigate the rosuvastatin's effect on the atheroma. Here high cardiovascular risk individuals without the CV events. So they are the high risk individuals without any event. So 6 months rosuvastatin treatment, about 20 milligrams daily was given. And the primary endpoint, reduction in the maximum atheromatous. And secondary endpoint, a change in the corrected uptake per lesion. And results. So 40 enrolled and 39 included. Rosuvastatin conclusion, rosuvastatin significantly reduces the maximum atherosclerotic plaque with subclinical atherosclerosis after the 6 months of the treatment. So at 20 milligrams per day. So definitely helps a lot in our population. So that is the inference of this study. LDL-C cholesterol variation, microcalcification activity. So this clearly shows that the plaque metabolism, atherosclerotic plaque metabolism, a subclinical atherosclerosis imaging study before and after rosuvastatin treatment, showing the reduction in the maximum plaque uptake in the coronary arteries, the carotid arteries, and the aortic arch. Rosuvastatin effect on the atherosclerotic plaque metabolism, a subclinical atherosclerotic imaging. Again, the rosuvastatin about 20 milligrams per 6 months. A beautiful reduction in the maximum atheroma and microcalcification activities, about 20% reduction. Rosuvastatin based lipid lowering therapy for high vascular risk patients. What is the importance of LDL-C reduction to decrease the risk of vascular complications? Efficacy of the rosuvastatin, intensive reduction about 50 to 55% with the rosuvastatin alone and 60 to 75% with rosuvastatin plus ezetimibe. So this is important take home point. So if you want to reduce the LDL cholesterol by 50%, so you can use the high intensity statins like rosuvastatin at a maximum doses, maybe 20 to 40 milligrams. Suppose if reduction is more than the 50%, say 60 to 75% reduction, so you have to take the help of the other drugs. Most important drug to be added to the rosuvastatin is the ezetimibe, because ezetimibe is nothing to do with your rosuvastatin action. It is mostly an intestinal cholesterol absorption inhibitor. So when the fellow is taking the more and more trans fats or the saturated fats, etc., so the cholesterol absorption will be inhibited with the use of this ezetimibe, and the common dose used is the 10 milligrams. So the Jupiter trial is an important trial. So a big boon to the rosuvastatin sales, the Jupiter trial. So like your HOPE study for the Ramipril. So after the HOPE study, the more and more prescriptions for the Ramipril, the same thing happened to the Jupiter trial, also to the rosuvastatin. So in the Jupiter trial, about 17,000 subjects with the LDL-C cholesterol less than 130 and high sensitive CRP, no known cardiovascular diseases. So they have given an importance to the high sensitive CRP also in these subjects. So this is the vascular inflammation mark. So high sensitive CRP should be less than the 1 and it should not be more than the 3. So that is very high risk. So here the duration, they stopped early after 1.9 years due to the positive results. So they have given nearly the 2 years study. So here the LDL-C reduction 50% with the rosuvastatin. High sensitive CRP reduction is 37%, indicating anti-inflammatory properties. So the rosuvastatin is not only reducing the cholesterol levels, but also it acts as an anti-inflammatory as far as the vascular inflammation is concerned. That is the biggest advantage for our Indian diabetics, our Indian atherosclerotic cardiovascular disease people, because we are having the more and more vascular inflammation, maybe because of our obesity, or maybe because of, in single word, maybe because of increased metabolic syndrome, we are having more vascular inflammation. To reduce the vascular inflammation, again, rosuvastatin will help you. See the implication. Rosuvastatin effectively reduces the vascular complications and mortality in hypercholesteremia patients without the prior indications for the statin therapy. See the Jupiter trial. The myocardial infarction reduction by 54%, stroke reduction by 48%, MACE by about 47%, primary endpoint by 44%, and death from any cause by 20%. So that is the advantage of the rosuvastatin after your Jupiter trial. What about the non-HDL-C cholesterol and the residual risk? See, the CV risk reduction remains a suboptimal with the current LDL range change of less than the 40% for low or moderate intensity statins. Here the Da Vinci study, the patients on high dose statins or the ezetimibe failed to achieve the lipid goals. Here only 1/3 of the patients at high and very high CV risk achieved their risk-based LDL-C goals with available lipid lowering drugs. So this is again very important. Even though you prescribe the statins, so don't be happy that all the 100% of this population will get the normal lipid lowering therapy results. So the only 1/3 of the patients are achieving it. So that means you need to do more than the statin therapy in some individuals. So about 18% high risk patients achieved LDL-C goals, whereas the 14% low intensity statins, 16% with the moderate intensity, and 22% with the high intensity statins. So overall, 37% patients receiving ezetimibe combination therapy and 57% PCSK9 inhibitor combination therapy achieved their risk-based LDL goal. So how well are we treating our atherosclerotic cardiovascular disease patients? Insights from the European Da Vinci study. See here, they have used the moderate intensity statins monotherapy, high intensity statins, ezetimibe combination, and other lipid lowering drugs like bempedoic acid or the PCSK9 inhibitor, that is a monoclonal antibody inhibitors. Here the majority of the patients receiving the moderate intensity statins monotherapy. Only 28% are taking the high intensity statins monotherapy. But our people, even though they are taking the low or the medium intensity, we have to upgrade. We have to uptitrate our statin dose, because a lot of our people, at least 80% of our population, they need high intensity statins. Few patients were receiving the ezetimibe combination. Again, very substantial group of our Indian diabetics or Indian atherosclerotic cardiovascular people group, they need a combination drug therapy with ezetimibe and statins. So the need for the combination, already I told you. So here another study, a Santorini study, the use of the combination therapy was lower in patients with a very high CVD risk at baseline, reluctant to achieve the target level. So additional lipid lowering therapies are needed to complement the current therapies. Here the treatment gaps in the LDL-C cholesterol among the high and the very high risk individuals. See here about the 44 patients, they take the monotherapy, and 21% no lipid lowering therapy, and about 24% combination therapy. So despite the lipid lowering therapy levels above the recommended values, the majority of the patients received the monotherapy, and 21.8% of the patients, they had no documented LLT. So as a clinicians, so you should all aware of these people. So even though they are taking the statins, don't be happy. You have to uptitrate, number one, or you have to give the combination therapy with the statin plus the ezetimibe or statin plus other lipid lowering drug therapies. And again, along with the statins, non-drug therapy is also very important. That is non-pharmacological management. The role of the diet, the role of the physical activity, cessation of the smoking, and reduction of the body weight if they are overweight or the obese, and more sleep pattern, sleep time, at least 7 hours a day, more fiber, less salt, more fruits. So this is the very, very, very important messages you have to pass on to all these population along with your statin therapy or with the combination therapy. So without this non-pharmacological management, so with the statins or with the lipid lowering therapies, so it is very difficult to reach your target of less than 55 or the 40 or the 30 of your LDL-C goal. See here the CSI guidelines, acute coronary syndrome patients. See here. So in the management of the dyslipidemia, the acute coronary syndrome. So you do not wait for the fasting. Immediately have to send the lipid profile within 24 hours. Non-fasting. Already you have to start at the 40 milligrams of rosuvastatin plus ezetimibe, or 80 mg of the atorvastatin plus ezetimibe. That is important. Again, a take-home point. In all the cardiac ICUs, so immediately you have to start either the 40 mg of the rosuvastatin or the 80 mg of the atorvastatin. Not the 10 milligrams of the rosuvastatin or the 20 milligrams of the atorvastatin, or not your ecosprin AV. So that means 10 milligrams of the atorvastatin and 75 milligrams of the aspirin. So I have to give 40 milligrams of the rosuvastatin or the 80 milligrams of the atorvastatin plus ezetimibe. And then the lipids at the 4 weeks. Your target is less than 55. You reached it, continue it. If you didn't reach that target, you still the LDL-C cholesterol more than 55 at the 4 weeks intervals, and I add the bempedoic acid. That means initially you have added the 40 milligrams of the rosuvastatin plus ezetimibe, and the goal is not more than the 55. After 1 month, again you add bempedoic acid. So most of our people, they need these 3 drugs to reach your target of less than 55. And still if it is more than the 55, then you have to use the PCSK9 inhibitors, which are very, very costly. So addition of the ezetimibe at initiation of the treatment is recommended, as alone high dose statin may not be able to reduce the LDL-C cholesterol. So in all high risk individuals in all the cardiac ICUs, so on the day 1, you have to start the high dose statins, that means 40 mg of the rosuvastatin plus ezetimibe, and wait for 1 month, and still the LDL is more than 55, you add the bempedoic acid. That is the take home message from this slide. So the Lipid Association of India guidelines is acute coronary syndrome. They divide into the 4 groups. One group, so I have not taken the statin at all. Or another group, patients with statin intolerance. And then the middle 2 groups are the patients on the low or the moderate intensity statins, or the patients on the high intensity statins. So 80% of our people, they are on either the low or the moderate intensity statins, and some people are on the high intensity statins. So on admission, send the blood sample for extended lipid profiles. That means in the acute coronary syndromes, don't be happy with the lipid profile alone. Please send the blood for the lipoprotein A also, in those people who can afford at least. So along with the lipid profile, you have to send the lipoprotein little a at the emergency triage. and stratify the atherosclerotic cardiovascular risk according to the Lipid Association of India risk algorithm and define the LDL-C target. So start or continue the high intensity statins plus ezetimibe. So here, so one another point here, CSI and LAI is you have to send the lipoprotein A also along with the lipid profile in the cardiac ICUs in all the cases of acute coronary syndromes. And again, you have to start the same thing. Drugs, you have to start the high intensity statin plus ezetimibe and continue the high intensity statin plus ezetimibe and consider additional available drugs like bempedoic acid or PCSK9 inhibitors. See, when you use the PCSK9 inhibitors, when the lipoprotein little a you are sending on the day 1 on the admission of this case, if it turns to be less than more than the 50, so then consider the PCSK9 inhibitors along with your high intensity statins and ezetimibes. So here the IMPROVE-IT study and another study, a combination of statin and ezetimibe more effective than the statin monotherapy. So for patients requiring the more than the 50% reduction, a combination therapy offers additional LDL-C reductions and higher control rates. This already I told you. So these are the different studies: Explorer, Gravity, Mrs. Roche, SPRE, iROSET. In all these studies, RSV means rosuvastatin, EZD means ezetimibe. So they have used the 10 milligrams, 20 milligrams of rosuvastatin, or 40 milligrams of the simvastatin, 80 mg of the simvastatin, or rosuvastatin 5 to 20 milligrams. But all here, the ezetimibe dose is a fixed dose, 10 milligrams. So the LDL reduction, see the less than 70% reduction, 60% reduction. And proportion of the patients that attain the LDL-C targets is about the 94%, 95%, 90% with this combination. So combination drugs, conclusions, combination that with ezetimibe and moderate intensity statin shows the favorable clinical outcomes and better drug compliance in all these patients. So again, the combination therapy. So if you see here, 3-year composite events of the cardiovascular deaths, myocardial infarction or revascularization, heart failure, etc. So very much reduced with the combination therapy rather than this high intensity statins. Here the red one is high intensity statins and the combination of drugs is the blue one. So here the 11.6%. This is a multi-center study, international double-blind placebo-controlled randomized trial. About 13,000, near the 14,000 patients. Inclusion criteria, see higher objective is to evaluate the effect of the bempedoic acid on CV outcomes in statin intolerant patients at high risk or with established atherosclerotic cardiovascular disease. So we see some population here. So they are an established atherosclerotic cardiovascular disease or at a high risk individuals. So if you start on the statins, they are intolerant to the statins. What to do? Now you got the answer. So now you have the drug, that is the bempedoic acid is available right now in the market at 180 milligrams of the dosages. So you have to use this drug. So that is the study of this American College of Cardiology, nearly 14,000 patients. See the changes in the LDL-C cholesterol and high sensitive CRP levels. So LDL reduction was greater with the bempedoic acid than with the placebo. Again, the high sensitive CRP levels reduction is also good with the bempedoic acid. So outcomes, so scores over the placebo therapy. So here the results. In conclusions, bempedoic acid offers cardiovascular risk reduction similar to the statins for a given absolute LDL-C reductions. Bempedoic acid is a viable alternative for the statin intolerant patients, providing the similar cardiovascular benefits through the LDL-C lowering. So now you got the drug to be used in all the statin intolerant population with the same equal reductions with the bempedoic acid. See reduction in the vascular events by the bempedoic acid compared with the statins. So this is the lipid lowering therapy for the high triglyceridemias. So we discussed about the LDL-C cholesterol. We discussed about the non-HDL-C cholesterol. And now the triglycerides. See, you all know, you all agree with me that we don't give much importance to the triglycerides at a doses of say 200 milligrams, even though the target is 150, even the 200, 250, 300, we give more of importance to the LDL and etc. But when the triglycerides are more than the 500, we have to give more importance because these people will get a risk of pancreatitis and also the risk of atherosclerotic cardiovascular disease. So here the lifestyle interventions required in all the population. So the low fat diet, avoid the refined carbohydrates, weight reduction and exercise, we avoid the alcohol, that is the binge alcohol or excessive alcoholism, and then no smoking. So control the secondary causes of hypertriglyceridemia, that is the diabetes and hypothyroidism, etc. So increase the LDL-C cholesterol, increase the non-HDL cholesterol, high atherosclerotic cardiovascular disease. So here you use the statins, etc. But here to reduce the triglycerides, so omega-3 fatty acids. Okay, more and more fish diet. Fish contains a lot of the omega-3 fatty acids. Fibrates, you have the phenofibrate, so maybe 140 milligrams. So initiate the statin plus HTMI to achieve the LDL-C targets. And if the triglyceride levels are still very high, then you go for the fibrates or the omega-3 fatty acids. So Lipid Association of India recommends use of statins plus HTMI initially, then consider the fibrates and the omega-3 fatty acids for the triglycerides management, because triglycerides can be easily reduced with your dietary approach or with your exercise. So still, and then first start the statin, the HTMI, and then with your intensive non-pharmacological management, you can control the triglycerides. Even then, after your intensive non-pharmacological management, if still the triglycerides are more than the 300 or 350, then there is a role of the fibrates and the omega-3 fatty acids. So Lens trial and the phenofibrates impact on the diabetic retinopathy. So the Lens trial begins under the Oxford Population Health. It is a participants about the 1,000 population. They receive either the phenofibrate or the placebo. Outcome measurement, eye disease progression is assessed at the end. Phenofibrate shows 27% reduction in the disease progression. So here LDL-C cholesterol and non-HDL-C cholesterol again. Apolipoprotein B and the non-HDL-C cholesterol better reflect residual risk than the LDL cholesterol in the statin-treated patients. Nearly 3,000 statin-treated. So I told you non-HDL cholesterol is also very, very important. And apolipoprotein B is a more accurate marker of the risk of the myocardial infarction and all-cause mortality risk than the LDL-C cholesterol. But most of the labs, they give only 5 markers. So you have to calculate the non-HDL cholesterol from your lipid profiles. I told you what you mean by the non-HDL cholesterol. That is also very, very important marker. The meta-analysis showed a 5 milligrams of rosuvastatin and 10 milligrams of HTMI had largely comparable lipid modifying efficacy and tolerability as the 20 milligrams of the rosuvastatin. See, most patients achieved LDL-C levels within first week, and effect was sustained at the 4 to 6 weeks of the follow-up. So this is all the among the lipid-lowering therapies: statins, bempedoic acid, ezetimibe, omega-3 fatty acids, fibrates. They reduce the serum CRP concentrations independently of the LDL-C or the triglyceride changes. See, comparative efficacy with rosuvastatin monotherapy and the combination with the ezetimibe and insulin sensitivity and the vascular inflammatory response in patients with the type 2 diabetes. So this very important study shows that combination therapy had a greater LDL-C reduction effect than the rosuvastatin monotherapy. So that is the reason for all the diabetic individuals. So better to give a combination of the ezetimibe and the rosuvastatin, not only to reducing the LDL-C cholesterol, but also a vascular inflammation, because the common cause of the death in diabetes is a vascular event. A combination of the rosuvastatin and the ezetimibe provided superior reduction in the total cholesterol, triglycerides, LDL-C cholesterol compared to the rosuvastatin monotherapy. So moderate intensity statin therapy with ezetimibe combination, it provides a benefit over the high intensity statins. So in summary, routine screening at the age of 18 years or at the time of the college admission, exclude the secondary causes of the dyslipidemia, use the risk calculator preferably to assess the lifetime risk score, especially in the younger age groups, stratify the patients in the various risk categories, LDLC cholesterol is primary target. The level of 50 is always safe. Non-HDL cholesterol is the next target and equally important in Indian patients. You have to get it from your lipid profiles. They don't enter this non-HDL cholesterol in your investigations. Non-statin drugs are also very important, especially ezetimibe, bempedoic acid, omega-3 fatty acids. In the fellow is having the high triglycerides or PPA or alpha agonists like fibrates. Lifestyle modifications are an integral part for the management and prevention of the dyslipidemia. This is a very, very important take-home point. So don't underestimate the value of the lifestyle modifications. Very, very important. So practice the primordial prevention. Practice the primary prevention. Practice the secondary prevention. Practice the tertiary prevention. Public awareness is essential to address this epidemic. So thank you one and all for giving the opportunity.